Hello, everybody. Whatever reason, my computer is taking forever to log on whenever I want to get on. But I am here. Hello, hello to folks saying hi in the chat.
Hello.
And hello. Alrighty, so today we are going to start talking about movement disorders and just kind of thinking about what's coming up to keep everything on your radars. So Tuesday, we'll keep talking about motor disorders. I meant to said mood, I meant motor, so apologies. And then a week from today, you have your next quiz, which will be about the sensory and the motor sections. And then also this coming Tuesday, the 21st, is when your topic preference is due for the group project. So you can do this one of two ways. You can either, if you know already who you want to work with, you can just turn in one. Hopefully we'll be in person and you can just hand me a piece of paper. We're still waiting for COVID test results. So we'll see. But if not, then I'll just have you email it to me. And it can either be individual if you don't know who you want to work with yet, or it can be with a group. Remember, on the syllabus are some ideas to get you started, but you don't have to use any of those. So you can come up with whatever you want. I've had people do some really interesting topics that way. In theory, it should be something we don't cover. I have had people do stuff that we cover briefly and I just cover less of it. Like, for example, I think in the past people have done like ADHD, which I normally touch on, but I can just sort of breeze over. But lots of really cool stuff you can do. I mean, I don't even know if there's any research out there yet, but I'd be interested to see if there's anything about COVID in the brain, right? Who knows? So those are your things coming up. Your midterm is not until the 7th of October, so it's right before fall break. I don't actually usually end up having midterms work out that way, that just sort of did this time. So there you go. Any questions about logistics of anything going on right now or coming up in the future? All righty. Well, since it's a new topic, and also just because I felt like Zoom on Tuesday was sort of flat. I think once you've been doing in person, it's hard to bounce over to Zoom, right, and feel the same vibe. So I'm going to have us start with doing the case study today. So let me go ahead and share this with you all. So what I've done, since we can't write it on a board, right, is I've converted the case study worksheet into a Google Doc that you will all be able to edit. And just a reminder, this is the case from chapter 15, the case of Dr. Jacobs. So you will be doing that. I'm going to assign you to Zoom breakout rooms. When you are assigned to your room, it will tell you the host is inviting you to join room whatever, and it'll be 1 through 5. Pay attention to that number, because that number will tell you which questions to answer on the sheet. I've actually numbered them for the groups. So, you know, if you're in group 1, you would answer the questions with a 1 next to them, etc. I'm thinking I'll give you about 15 minutes. I'm not sure if that'll be too long or too short, right? It's not quite as easy as when we're in class and I can just sort of look like, yeah, it looks like everybody's just about done. You know, if it's too long, bounce back into the main room whenever your group is done, or you can just keep talking amongst yourself about topics for class. If it's not long enough, you can send one person back to the main room and I can adjust the time as need be. So let me go ahead and create those breakout rooms. So again, if it's been a minute since you did these, you'll get a little pop-up notification and it'll say the host is inviting you to join breakout room. You just click OK. It'll take you there. While you're in your breakout room, there will be a little question mark at the bottom of the screen where like your camera and mic settings and all that are. So if you want to ask me a question, you can just use that and it'll tell me to go to your room. You also, if you go to where you typically like leave the meeting, it'll allow you to come back to the main room if you wanted to come there and ask me a question. So let me go ahead and do 5.
I have a quick question.
Sure.
And forgive me if you said this and I missed it. Are we doing in our groups the entire case study or a portion of it?
Just the one that has the number that corresponds to your Zoom number.
Okay, thank you.
Good question. Yes, and then I'll be able to just post this, or if you prefer, you can like make a copy for yourself and take notes there, whatever works best for y'all. All right, so I'm creating the breakout rooms. There will be 3 to 4 people in each room. I am going to make it for 15 minutes. And then after the 15 minutes is up, you will get a notification that you have another 60 seconds to wrap up what you're doing. So again, once I hit open rooms, you're going to get a little pop-up. It says to join room number, whatever. Pay attention to that number. Make sure you have the Google Doc open for yourself already, so you don't have to bounce back to the room and grab that link. All right, so here we go. Okay, well, welcome back, everybody. I'm going to go ahead and share screen, and we can all just pretend this is our whiteboard. There we go. Need to make sure I'm on. I don't know about y'all, but I have times where I have multiple browsers open, and so I needed to make sure I was on the correct one. So let me go ahead and make this big enough that hopefully y'all can read it, and we'll just sort of pretend this is our whiteboard and do this like we did in class last week in terms of walking through everything. I'm going to go ahead and get the chat open in case anyone needs to ask questions that way. I'm also going to pop open my participants window just in case anybody wants to use the raise hand feature. So lots of options, lots of ways to contribute. So we'll start with group 1 and have them walk us through everything. And like I did last week, I'll just add anything that I have down that you didn't. And sometimes it's just, I put it in a different place than you would have. So first group was Macy, Michaela, and Trayvon.
So for the identifying information, it was Dr. Robert Jacobs, MD. He was a male and he was 58 years old when he first started to experience symptoms. For some of the background and history, Robert began to notice like shakiness in his left hand, and he felt that he had to put his hand in his pocket to stop the shakiness. Since he was like left-handed, he had to do everything right-handed, which was like throwing everything off for him. The tremor would return randomly, and he was reported like sleeping problems because of his inability to move into a comfortable position, as well as like when his anxiety increased, the spasmodic tremor also returned with it. And yeah, I think that was it.
Great. Yeah, and I just have a couple other things. So one is that the tremor started while he was giving a lecture. Ironically, the lectures he would give were about the disorder he has, right? And in terms of his family history, his father experienced tremors as well. So there's probably something genetic going on there. Oh, thanks, Sophia, for typing. I was like, oh, I should be typing this. So thank you, Sophia. I appreciate that. And that his son, who was also a doctor, is the one who had to be like, hey, Dad, you should get this checked out, right? So sometimes it really takes someone other than ourselves to note, like, there might be an issue here. Excellent job, group 1. Okay, let me scroll down and have group 2 talk about the symptoms. And the group 2, sorry, is Emily, Hannah, Henry, and Lola.
So basically there's just like tons of symptoms to Parkinson's disease, starting like most obviously with tremors and muscle rigidity. But a lot of these symptoms, as I was going through them, kind of play into one another. As they said in the background, like muscle rigidity causes discomfort while sleeping, which leads to that being another symptom. Depression, as we spoke about, is a side effect of a lot of these disorders, just because it's difficult to do the things that you were once proficient at. But as far as cognitive symptoms, there's frontal lobe impairments, so difficulty planning ahead and organizing, mental shifting. I thought it was interesting that they can remember the content of like popular events like the assassination of JFK, Watergate scandal, but they couldn't put them in order of time. And they had impairments on spontaneous recall. So when they were doing the memory tests that would give you a stimulus to kind of jog your memory, they did well with that, but coming or just trying to come up with things freely was a real challenge in their memory.
Yeah, I think you hit on just about everything. Yeah, and you've got the postural instability. That's really a hallmark feature of Parkinson's. I usually try to model this in class. I don't know if I can do it in the amount of screen I have here, but essentially like they lean forward. And so it's like they're always kind of like going faster than they want to. The only other thing I had was when he walked, his left arm swing was slower. And yeah, that's that's good. I think that's great. Okay. Next, we will move on, and thank you to Emily for typing that in for me. I very much appreciate it. Y'all are awesome, by the way. Next, we'll move on to the testing results, and this is group 3. They'll also do diagnosis for us, although we've all kind of figured out it's Parkinson's. And this is Haley, and Sasha. Zoom likes to put people with the same first name together, I've noticed. So there you go. Anyone
Sorry, I was trying to get my thing to unmute. It was like my keyboard was being weird. So at first the doctor suggested that it was too early to diagnose him with it, but he was going to be like aware of the symptoms and monitor himself with the cognitive problems that he had and what he could do to compensate for them during the time. And the neuro assessment of the 12 cranial nerves and Robert's reflexes, his walking and turning. And after the examination, Robert was exhausted, which isn't normal. And after taking I don't know how to pronounce that, pallidometry test, his left-sided bradykinesia was reduced, and in result, he reduced his medication. He had a high IQ and he did really well on all of his verbal tests. He became very frustrated during most of his tests as they became more difficult. And he would need to start monitoring his systems carefully so he could be started on medication if they interfered with his practice in life. And he had a mild impairment on some of the performance tasks because he was slower than others his age.
Excellent. And then whoever wants to do the diagnosis real quick, and then we'll just talk about both. It's okay. It's Parkinson's. We all know. It's good. Yeah, this is excellent. I only had a couple. Oh, it's okay, Haley. Yeah, I understand. I have issues sometimes as well. This actually reminds me to double check something. I think it's recording. Hopefully it's recording. Yes, it is. Okay, good. I paused it while you were in the group, so we didn't have just 20 minutes of my face. So the only other things I have are just some of, I think you all summarized it, but just some of the other issues he had on the actual tests they gave him. So on that Ray-O complex figure task that we looked at, he showed some visual spatial problems and executive dysfunction. And looks like Haley's going to take over for me. Great. I was just going to type it in. Could also see executive dysfunction from the Wisconsin card sort. And then later in this, most of this case study is when he was initially diagnosed. Later on in his diagnosis, he had some problems with new verbal learning. So learning new things, learning new list of words, things like that. Yeah, so I just can't imagine, right? So this guy is probably pretty comparable to an academic, if not higher up, right? In terms of his abilities, his abilities, what was I trying to say? His facilities, his knowledge, his intelligence, and then it just goes from him. That's heartbreaking, right? Alrighty, so next we'll have group 4 talk about the impact on his life and that of his family. So this is Amanda, Brittany, and Miranda H.
So he experienced, as we were talking about before, depression and anxiety, and especially when so he went to speak with a clinical psychologist about that and get some help. He had poor self-esteem. He experienced loss of confidence, and he had difficulties in personal relationships. I don't know what else. I guess that's supposed to be like maybe verbal. And then becoming wheelchair bound in the near future, he like realized that for himself. And then keeping a positive mindset was one thing that I noticed that a lot of people that have Parkinson's or any other disabilities, sometimes they'll develop that negative mindset. But it stood out to me that he had a positive mindset, that he wanted to continue to do anything he could to take care of himself. So his verbal memory was not much worse than the memory of many of his friends. He was frustrated with his wife when she told him to get a checkup, but he listened to his son, the doctor, which I thought was interesting. He took the time to really enjoy his retirement. He has not lost the abilities most important for his quality of life, which is a really cool thing because some people with Parkinson's may have problems with their quality of life. He still enjoys reading, listening to music, playing with his grandchildren, and even I was like, wow, even making love to his wife. Okay. And then he would also sometimes wet the bed, so he and his wife would have to sleep in separate rooms. So those are just some of the impacts that he had.
Excellent. Yeah, I think I've had everything you all had. The only thing I had in addition to that was that his son actually developed a special interest in Parkinson's. Maybe not surprisingly, because his dad had it. So if you're already a doctor and someone in your family gets something, right, then you might become a little more interested in it. So I'll just throw that on the bottom.
All right, thank you.
I gotta help out a little bit here. So it's not like a negative effect, right? Sometimes you get sort of positive things out of this.
Yep.
Great. Last thing we have is our room 5. We're looking at treatment and effectiveness. So this was Debbie, Miranda W, and Will.
I can start. So they started with levodopa. He did okay on it for about 5 years, and then on-off syndrome started to have a really negative impact on his life. And it got worse because they had to consistently raise his dosage over that time until the negative impact started to outweigh the positive. He did note that golfing and swinging the golf club aided in rigidity until his dyskinesia became overwhelming and he could no longer golf. At the point when L-DOPA was no longer an appropriate treatment option for him, he became interested in surgical intervention, and as another group said earlier, was in an assessment program for palidotomy and was deemed a suitable candidate. After he got his palidotomy, which is radio frequencies causing microlesions in the globus something, globus pallidus interna. He had improvement on his left side bradykinesia and reduced rigidity. It reduced his on-off syndrome and improved his facial mobility. After that, they followed up with deep brain stimulation funded by a research project. It slurred his speech slightly, but he noted that a magic wand effect allowed his tremors to stop. He did understand that the treatments wouldn't be long-term, but the improvements in his quality of life outlasted what they expected. At the time that he was older, like further into his retirement, he noted that especially his cognitive difficulties were, he thought they were probably no worse than the average difficulties of his regularly aging peers.
And I just want to add, because we talked about it, his positive outlook. And I think it was in the textbook talking about how people with Parkinson's, when they have a more positive outlook, they tend to do better and, feel better throughout the rest of their life versus, with the negative mindset, those people tend to, have more of a downward spiral and maybe more symptoms because of their negative outlook on things.
Yeah, it's that mind-body connection, right? And so this doesn't mean that, having a positive outlook is going to automatically make things rosy shiny, right? For sure. And that it'll magically make you better. But what it does mean is that it can help, for sure. So while I'm actually thinking about it, I am going to create a new content area on Blackboard for study sheets. And I will link this there so that y'all can go back and reference this at any time. You'll get to see a little behind the scenes of Blackboard here. So it's so exciting. And what I'll do is I have notes for the other one that we have done, and I will post that as well. And then at the beginning of each semester, I'll just have to hide it so that the new class can actually engage with it with fresh eyes. So awesome. So I'm going to stop share for just a minute. We'll go back in a minute because I do have some videos to show you all today. And I wanted to talk a little more about the palidotomy, which I think is how you pronounce it, but I don't know if I know any better than y'all, to be honest. So, so as the last group described, this is a procedure where a tiny electrical probe is placed on the globus pallidus, which is one of the basal ganglia. And then it's heated to 80 degrees Celsius, which is pretty darn hot, actually, for 60 seconds. And it basically is purposely destroying a small area of brain cells. So it's specifically used to treat these dyskinesias, which is what it helped him with, right, in patients with Parkinson's. So again, they're creating a scar on the brain, basically. And it reduces the brain activity in that area, which in and of itself helps relieve the movement symptoms like that tremor. And just to kind of show you all what a resting tremor is. So resting tremor would be if I'm just sitting here, right, my hand would be tremoring. But if I went to do something like get my drink, it would stop. And then it might start again. So just for an example, I know someone with Parkinson's who's a very talented guitar player, and he can still play the guitar just fine because when he's doing something active, he doesn't have his tremor. But I remember one time he was speaking at church and you could see his tremor sort of down by his side while he was speaking. So certainly we could, see that in action. So what they do before a palliatotomy is they would do an MRI to identify the precise locations they want to do this. Here's the fun part. The patient is awake during the surgery. So you can imagine having brain surgery while you're awake. Like, it's just sort of mind blowing for me, right? And so the scalp area is totally numbed with a local anesthetic, so they can't feel it, right? But they're doing stuff to your brain, right? And so the surgeon inserts a hollow probe through a small hole drilled in the skull to its target location. And then there's liquid nitrogen inside the probe. And it could be either with the cold or it can be with the hots. You can do it either way. The liquid nitrogen would be if you're doing the cold destroying. Then obviously you would close it and the wound would be closed. And they usually require you to stay about 2 days after, depending on whether or not there's complications. Oh, very interesting. Yep, that can happen as well. And as they point out in this case study, palliatotomy is kind of going out of fashion, and much more likely now they would use DBS, deep brain stimulation, instead. So deep brain stimulation is essentially like doing a pacemaker for your heart. So they install this medical device that sends electrical impulses to specific parts of the brain. So it provides remarkable therapeutic benefits for otherwise treatment-resistant movements and affective disorders. So chronic pain, Parkinson's, tremor in general, and dystonia. This is something interesting, and this is not unusual in, I guess it's more psychiatry or neurosurgery. We don't, as much as we've been doing DBS for a while, it was first approved in 1997 as a treatment for Parkinson's. Oh no, in 1997 was just for tremor. Sorry, Parkinson's was 2002. We still don't understand exactly how it works. And I'm kind of laughing because even though we've been doing electroshock therapy since really electricity existed, early 1900s, we still don't really understand why that works either. So it basically changes the brain activity in a controlled manner, and it is reversible, which palliatotomy is not, right? You make a scar on the brain, you can't unscar it. So that is sort of nice. So there are obviously some risks for complications because you're inserting a foreign object into someone's body, but again, no more so than a pacemaker, for example. And the other thing that I should note is that DBS is showing a lot of promise for treating major depressive disorder as well. So, it's not just these physical things, it's also mood disorders potentially too, which again would potentially eliminate the need for doing things like electroshock therapy. So.
Something Will and Debbie and I were talking about was that it still seems extremely primitive, the treatments that we have available. Kind of like, way back when it's like, wow, you seem sad, time to do cocaine about it. Let's drill a hole in your depression. And now it's, wow, you're shaking, let's literally burn your brain. And it feels, obviously if it works, but it feels like probably in 100 years, we're going to look back and be like, what were we doing to people?
You have ghosts in your head. You should microdose meth.
Yeah. Well, and I don't know how much other people are following this. This might also be actually like an interesting group project topic, but now they're starting to use LSD and things along those lines to treat certain psychological disorders. And there's a lot of research on it and it seems to be working, but I kind of wonder okay, but what about the side effects, right?
Well, there's a lot of studies on lots of hallucinogens. We actually had a student here, and I can't remember her name, but she went to a conference with us for, she did projects here and at ODU, and she went to a conference for sociology where she was talking about the positive effects of psilocybin. And then the esketamine trials have gotten a lot of headway. They're doing really well.
And the sort of ironic thing about this is that they were testing this in the 60s and sort of abandoned it. Especially our realtor who helped us buy the house I live in is also a friend. And she's told me stories about when she was in college doing studies like you all do, except the studies would be, they would like give her hallucinogens and like see what happens. Again, IRBs weren't as much of a thing back then, right? So shout out to Drugs for running the war on drugs. I love it. So yeah, it's sort of interesting to think about, like, is this going to work? Can we, we are pretty advanced in terms of chemistry now, right? Can we dial this in to be something that's helpful without the side effects potentially that you can get, right? And all medications have side effects. So something else to sort of just bear in mind, right? So yeah, I think it's a really interesting topic that I don't know that much about, but I know tons of journal articles coming out about it. There are books about it. I heard a story on NPR once about it. So definitely something interesting in terms of, this seems to be working. We can kind of figure out why, but we don't know for sure. Yeah. Cool. Well, let's keep talking about Parkinson's, even though it's not the start of your SGA. But just since we've already been talking about hello, Debbie's cat, just we're here. Let's keep going. So, it was discovered by a guy named James Parkinson. Oh, TMS. Yes, actually, let me take a sidestep and talk about TMS real quick. So TMS uses magnets to essentially do some of the same stuff that DBS does, but it's non-invasive. So it's, you kind of just sit in a chair and they aim it at different parts of your head. It almost looks like you're getting an X-ray, basically. And it's very effective. And again, it's one of those things that's like, we kind of know why, right? But like, yeah, there's actually some researchers at EVMS who do TMS as a treatment and do research on it as well, which I had an intern work with them a few years back, and I was just fascinated by everything she told me. Yeah, I think that that might be really cool, but I think they're super expensive. I'm gonna open a side window and Google it real quick just to see.
Well, I mean, because students, both high school and college, have the highest depression rates nowadays of any other point in time in history. If this is something that works, I feel like it's something worth looking into.
Yeah, it looks like here's a refurbished one. It's just the readout system, not the actual machine. That's about $3,000. Looks like the actual one might be more like $60,000.
Virginia Wesleyan can absolutely afford something like that. I refuse to believe that they can't.
I wish we could. There are years we run with only $20,000 extra above our budget. So I'm hoping that with the great endowments that Dr. Miller is talking about, we'll start to feel more comfortable financially. Yes. Yeah, I think this is a problem in general with treatments, right? Is our insurance dictates in general, but even more specifically for therapy and mental health disorders, our insurance dictates how much treatment we can get, right? And so, for example, most courses of cognitive behavioral therapy, which treats a whole host of disorders, a lot of research behind it, are about 12 to 20 sessions, and the typical insurance plan will cover 8 for a year. I mean, the therapist can request more, and sometimes they will grant it, but there's no guarantee. Right? Yeah, it is complete horseshit. Like the APA, to their credit, as much as they've had some issues with ethical things in the past, they are doing an excellent job really advocating for mental health parity. Which means that mental health would be covered essentially at the same way that physical health would. So they've made some strides already. There was some stuff in the Affordable Care Act which you may know as Obamacare. Same thing. And so, but it's not perfect, clearly.
When I worked at the Norfolk City shelter, and I'm working for the city of Norfolk, and I had some kind of a health crisis was causing like vertigo and a bunch of other stuff, and they kind of linked it down to some things that were stemming from like unchecked major depressive disorder, and the city paid for me to go to 2 sessions, but then that was that, and the insurance wouldn't cover it. So it was like, well, your mental health is suffering and we need you to get that fixed before you can come back to work, but we're only going to let you go to 2 sessions. So figure it out. It's awful.
For anyone who's been to therapy, the first session is your intake. So you're just like finding stuff out, right? So then it's like magic 1 session therapy, pretty difficult to do, right? Macy, yeah, sharing that it's pretty darn expensive, right? And this is sometimes just newer treatments are that way where the insurance isn't willing to cover them yet. Yeah, there are like self-help CBD, CBT things that you can follow now as well. And yeah, I mean, it's sort of like, you got to weigh your pros and cons. Obviously, try to do it under a doctor's supervision if you can, right? And stuff like CBD is getting easier in our state because they're trying to legalize medical marijuana and whatnot, right? But yeah, it's difficult to navigate, right? And if you switch insurance plans, for example, then all of a sudden the medication you've been taking might not be covered anymore, and you've either got to pay out of pocket or switch meds. So yeah, very difficult. And again, like mental health is often more difficult to access care for. And that can include things like we're talking about right now, like things like Parkinson's that clearly have a biological component, right? We know what causes Parkinson's. It's apoptosis. It's too much programmed cell death in the brain, right? And yet, like some of these treatments might not be covered, right? L-DOPA is very expensive. For example, DBS is very expensive. And again, even though these things have been out for a while, sometimes they're still considered experimental and insurances won't cover them. So
Even just regular therapy is expensive.
yeah. I told the story, and I don't think I told it to y'all this year, but the reason I always say like go to the counseling center because it's free is when I was on my residency or my internship year, I saw a client who didn't have any mental health coverage on her insurance. And she and her husband were wealthy enough she could pay out of pocket, but she had to pay, I think it was like $150 or $175 per session to see me. Plus, I think it was another $100 facility fee on top of that. And I didn't set that, the facility did, right? If it were me, I'd be like, I don't know if I'm worth that yet. I'm not licensed or anything, right? But yeah, I mean, she did it. It was great. She ended up being one of the clients I saw the most improvement in. But yeah, it makes it a lot of therapists who live in big cities tend to not even bother taking insurance because of all the hoops you have to jump through. And so they might have like a sliding scale for people based on income. Or I have a friend who works in a smaller town and is able to set her rates at something that like she essentially like makes a little money and can pay her rent in her office space, right? Because it's like an extra on top of a teaching job. So yeah, there are, I'm now deep into therapist Twitter. I keep finding these pockets of Twitter that are so interesting. And for a lot of therapists, it's actually really hard to live off insurance reimbursements because you might charge $100 for a session and then they reimburse you $30, right? And so now for an hour of work at a very high educational level, right, with no hint of reimbursement for any paperwork you have to do outside of that, you know, you're getting $30, right? And you've got to, like, if you're in a private practice with other people, you have to pay a percentage of that to the practice. You have to pay for your rent. You have to pay this, that, and the other, your continuing education credits. So you continue to be licensed. And so it can be really difficult for people who, again, are trying to do it. Yes, yay. Oh, that's really good to hear, Miranda, that you've, it sucks that you've had to like bounce between people, but that they've all been good. And it sounds like you probably had good turnover, good continuity of care. Yeah, I mean, we are a training site. So Bill and April will supervise interns often from Regent, I know, and I think some other places as well. And these are not like, it's not their first rodeo. You're not their guinea pigs, right? They're getting towards the end of their training. So they know what they're doing. It would have been comparable to like me on my externship or my internship year. So yeah, very great. Obviously we don't have the stuff to like treat Parkinson's, but depression, anxiety, they do tend to refer out for more specialized things. So like if you had an eating disorder, they might try to refer you to someone else in the community just because they want to make sure you're getting the proper treatment for that. So, and again, I have a lot of resources, a lot of connections in the area. So if you ever do need specialized care, I am glad to provide you with that list of contacts. So, or Google it if I don't know it. I've done that for people too. All right. Well, that was a little tangent, but I think really important to the clinical aspect of clinical neuropsychology, right? So like, even something like you're trying to do a big assessment, right? Will insurance pay for that, right? Becomes an issue. I know at our training clinic, for example, all services were free to students, but for neuropsych exams, we did have to charge money just to like pay to offset the cost of the materials, because like every score sheet for like a WACE costs money. And people would pay, it was like $50, whereas, you know, if you didn't have insurance and you went through a full battery, it'd probably be like thousands, right? With a full price, hopefully trained neuropsychologist. So, but yeah. Yeah, I mean, there are mental health professionals, but yeah, there's not a lot of support here necessarily for them. The one issue that I know a lot of people have run into in this area is a lot of the mental health professionals in our area are religiously based, which is not an issue for some people. But if you are not religiously based, right, it can lead to a real like unhelpfulness in that. So, alrighty, I'm going to try to bring us back to Parkinson's, but this was excellent. Yes, there are like 3 people I know who treat eating disorders, but I know all of them and I have their contact info if anyone ever needs it. So, let me talk to you about trying to find someone to treat my postpartum depression. There's like literally 1 psychiatrist, maybe 3 therapists that do that in all of Hampton Roads. So that was fun. But yeah, so, but if you have something like Parkinson's, right, it might be a struggle, even if like, let me give you another example of how care can work or not work, right? Let's say you're a veteran, so you can use the VA, right? All VAs are going to have basic services. And if it's a Veterans Affairs Medical Center, the VAMCs, they should have some psychological services as well. But if you have something specialized going on with you, there might only be 1 center within like 500 miles that does that treatment. So to give you an example, when I was on our spinal cord injury unit, while I was on residency in Augusta, Georgia, there was someone from Asheville, North Carolina, who came to Augusta because that was the closest spinal cord injury center for him. So, you know, accessing treatment can be quite difficult. And so this is a big push within psychology, is to try to make it more accessible. So we're trying to do things like put psychologists in healthcare settings, like primary care settings are more and more trying to have a psychologist on site. So rather than the doctor being like, well, you know, let me give you some referral information, they just walk you down the hall and they're like, here's our psychologist, you're going to talk to him right now or her right now. So that's really good. I think I really like that initiative. All right, let's talk about James Parkinson. So he was a London physician, and it was back in 1817 that he first started describing this. So some of these disorders we've started describing before psychology was even a field, right? Psychology didn't really exist until the 1870s. Psychiatry did and medicine did, clearly, but it's just so interesting to kind of think about that. So interestingly, his research was he did essentially observation, where he just watched people with this disease on the streets of London. Even today, this might be considered okay if you're not like revealing any personal information about someone. Like this type of research is generally considered fairly low risk, unless you're like photographing them and you can tell who it was, then it's an invasion of privacy, right? So this is like decently common worldwide. It's up to 1% of the population, which again, may not sound like a ton of people, but if you figure we've got 7 billion people plus, right? That's 7 million people worldwide who would have Parkinson's. So it's a lot. So as we've already mentioned, we've got some basal ganglia affected here, pulling into the movement portion. We also have degeneration in, I'll type this one out, substantia nigra. We tend to see a loss of dopamine as well throughout the brain. And the symptoms will vary from patient to patient, and they can just look like changes in motor activity that occur when you age. And so like it can be kind of like with our case study, right? It was hard to determine like, is this just a thing of aging, or like his son had to notice like, no, you have a tremor, that's something different, right? So yeah, as we saw with our Dr. Roberts, yes, Dr. Roberts, our case study, he had the resting tremor, he had the rigidity in his muscles. So basically what happens is your extensor and flexor muscles have increased muscle tone. So instead of doing things smoothly, it's sometimes called cogwheel rigidity, where you just sort of, it's almost like a second hand on a clock instead of a smooth movement. And again, you're not consciously doing that. That's just how you have to move. And it can make all movement difficult. There are a couple different types of involuntary movements besides the tremor that can be involved here. Again, throwing this in the chat so I don't have to try to spell it out loud for you all. This is a cruel restlessness where you just can't sit still. It's like constant changes in posture. And then I've discovered I can't. I can type at the same time. I had to stop typing to do that. All right, so this crisis is where you involuntarily turn your head side to side. We've already talked about the disorders of posture, where they sort of lean forward, and that can make walking difficult. And that can go in tangent with their disorders of equilibrium, where they have difficulties in standing or sitting unsupported. They have a really hard time with balance. Difficulty in achieving a standing position sometimes because of that. That's called a disorder of writing, RIGHT. And we talked about the locomotion, the type of walking that I mentioned, right, is festination, where they kind of lean forward and take faster and faster steps. It's not fenestration or defenestration. That's something else that's getting thrown out a window, right? They'll have absences of tone in their speech sometimes. And then they'll also have what's called akinesia. And that is slowness of movement. And it can end up with like a blank look on your face, sometimes lack of blinking. And then they'll just sometimes just sit for hours. It tends to begin, as it did for Dr. Roberts, with the tremor. And this tends to last for a while. A lot of these degenerative diseases, we'll learn more about this when we talk about memory disorders as well, are very insidious. So 10 to 20 years of progression of this disorder that you're living with.
Look at Michael J. Fox.
Mm-hmm.
He's been dealing with it for at least 20.
Gosh, longer, because I think he
Almost
started getting symptoms in
30.
the 80s, so probably like 30 years at this point.
Yeah.
I mean, granted, he clearly has access to the most expensive care, right? But yeah, actually, I'm glad that you brought him up because I'm pretty sure I have a video about him so that I can show you all, so you have a little bit of a feel for what this is like. Yep, here we go. So this is him talking about his Parkinson's disease. So if you're not familiar with Michael J. Fox, you should be. No, I'm just joking. So Back to the Future, he was on a sitcom in the 80s, and he developed Parkinson's really young. Like, I think it was like his 30s, like it was really young. And so he has become a real advocate for treatment for it. He has a foundation to try to find treatments for it. So this is just a brief video of him talking about what it's like.
Back to the Future was a film that helped define the 1980s and made Michael J. Fox a star. More hit movies followed, as did a string of awards for his TV series like Spin City. Now, though, his future's increasingly defined by Parkinson's disease.
As soon as I wake up, I can't go back to sleep. I mean, it starts going. So I would say that's the toughest part in the morning is to kind of go, well, I'm up whether I like it or not, I'm up now. And the other thing that happens to me in the morning, first thing is I get that dystonia, which is kind of cramping, and it can be very extreme.
In a rare interview on BBC, he spoke about the new challenges from something as simple as using a toothbrush.
Because I have to put the brush down on the countertop, hold it flat, and get the brushes on, because if I hold it, I'll miss it. It's a moving target. But anyway, once I get all loaded up, then I just kind of bring it up to my mouth and then just let it go.
Remarkably, he also revealed that ice skating appears to temporarily block his symptoms, but only while he keeps moving. There's no cure for Parkinson's, but Michael J. Fox has been fighting to change that. He's gone from actor to activist, campaigning for politicians backing stem cell research, which might offer hope to Parkinson's sufferers. Millions have seen the powerful TV campaign he made a few years ago.
They say all politics is local, but it's not always the case. What you do in Missouri matters to millions of Americans. Americans like me.
Michael J. Fox returns to ABC with an...
He devotes much of his life now to raising awareness about Parkinson's. And after many years off the big screen, he says he still watches his old life on the small screen.
At any given moment, I can flick through the channel and see myself. And for a long time, it was just like I stumble on an infomercial or something and just keep clicking. But now, every now and then, I will stop and watch it a little bit, and I'll just enjoy it. I'll just enjoy it for what it is and the time it was in my life. And I don't have any... There's no wistfulness in it. There's no longing in it.
Richard Lister, BBC News, Washington.
Very honest, extraordinarily brave.
Very candid, yeah.
The British accents. So you can see how he moves, you can see what it's like to live with it. And one of the things they mentioned was stem cell research. And I just have another quick video about this. And because I know one of your questions on the SGA asked about sort of the ethics of this.
Yesterday, I took children's classes at summer camp. I see all the kids all staring at my arm, and so it reminds me to tell them that I have a disease that older people get that makes my arm shake, my hand shake. And this little girl yesterday, she came over and she held my hand and she tried to stop it from moving, you know. And she says, "It does shake, doesn't it?" And I said, "Yes, it does." I first noticed my Parkinson's because of the tremor, and I read about the Parkinson's Institute and called and made an appointment. On the appointment slip it says, "Why are you coming here?" And I put on there, "I want to know what I've got." And I saw Dr. Wong, and he diagnosed a definite Parkinson's.
Parkinson's disease is one of the major neurodegenerative diseases of aging, Alzheimer's being the other. Probably affects over 1 million people just in the United States alone. The classic symptoms most people will recognize is shaking hand, slowness of gait, rigidity of the muscles, a stooped posture. It is a progressive disease and it's incurable. We do have very good medications that can help on a day-to-day basis. The big problem in Parkinson's disease is that sooner or later we get side effects of therapy. and those can be worse than the disease itself. So ultimately, these therapies don't really help patients anymore. There's a big emphasis in our disease, in addition to medications, for exercise, dance, yoga. Anything that helps with movement and keeps patients moving seems to be of benefit in this disease, and we believe it's as important as the medications. There's a desperate need to find some way to intervene to stop the progression of the disease or reverse the progression of the disease. That's the major focus in the Parkinson's field right now. We can't get to the area of the brain in Parkinson's that's affected. It's deep in the brain. It's called the substantia nigra because it's not accessible. We would damage the patient irreparably. So we don't have a way to actually get real Parkinson's disease cells from humans. With the CIRM grant, we actually will have the funding to get cells from living Parkinson patients, skin cells say, drive them back to stem cells with new technologies, and then forward to those very same cells that die in Parkinson's. Once we've done this, we will have for the first time the opportunity to study disease mechanisms in a culture dish, a way we never could before, but I think even more importantly, to test for new drugs to treat the Parkinson's disease patients, and that could be revolutionary. One of the most important things, in my opinion, in terms of both medical research and patient care, is that they somehow communicate with each other. We can go from discoveries in the laboratory right up through clinical research and clinical trials to test new drugs without ever leaving the building. And it happens because it's a very seamless system here where all of us communicate and things can move very efficiently and easily right up from bench to bedside, if you will.
I'm not a technical person. I don't really understand all the research that's going on, but I volunteer for everything that comes along. I'm constantly in the nurse's office saying, you know, what's new, what can we do, and looking at their board up there. There is some urgency, as Michael J. Fox points out. There is some urgency. We're getting older, and we would like to see the cure in our lifetime.
Random thing, I really liked that the closed captions turned that to the band The Cure. I would like to see The Cure. I did also really like the Michael J. Fox clip because he shows he uses some humor with it, right? He had a short-lived show about living with Parkinson's for a minute, and he used a lot of humor in that. He's not afraid to poke fun at himself, you know, and certainly we shouldn't poke fun at other people who have any sort of disability, right? But like for someone to be able to use humor to cope is really great. But yeah, so you can see there are some really great studies going on with stem cell research, and some of the, that was my favorite, the thing about the toothbrush, or like trying to find the toothbrush is a moving target, right? But yeah, so there are some really nice advances in stem cell research, and the idea of using like skin cells from the person, right, allows you to circumvent the ethical quandaries related to stem cells when people get really concerned when they come from like fetal cells or things like that, even though those would be fetal cells that would be discarded. So anyway, that's, you know, it is an ethical thing that comes up for people. So just wanted to say that. All right, we'll end there for today. I will keep you all informed. Hopefully we'll be able to be back in person next week, but we're just waiting to hear back from the PCR tests. So take care of yourselves and have a good weekend if I won't see you tomorrow.